Okay, so I'm just going to echo again Dr. Bernstein's message that, you know, if you are coming to see me, then we've sort of failed you in the sense that we haven't prevented this curable disease. So let me get started. So you've seen this slide just before. And this is, of course, the bad news, that there's about 150,000 cases of colon cancer diagnosed each year in the United States, and unfortunately 50,000 deaths. But the good news is that we have made progress in the numbers of colon cancer that we're seeing in the United States. And as you can see, these arrows show the decline in incidence between 1975 and 2006. There was a little blip between 1980 and 85, but since then, incidence rates have been declining. And similarly, survival rates have also been increasing. So we're doing something right. And so what are the things that we're doing right to increase survival and prevent this disease? So there are three main things. We're doing prevention. So screening has been discussed a lot in terms of colonoscopies or virtual colonographies allow for detection of polyps and their removal, and therefore prevention of development of cancer. We also are screening. So screening means we're detecting cancers that have already developed at an earlier stage where they're curable. And then finally, there have been advances in the treatment, including both surgery and chemotherapy, which I'll talk to you about. So here's a graph looking at the trends in colorectal mortality. And as you can see, they've decreased over the last 25 years. And the main contribution to why they've decreased is from screening. So those colonoscopies, again, I'll keep stressing this. Screening saves lives, and this is pointed out here. Another factor that has led to the decreased mortality is change in risk factors. So quitting smoking, active lifestyles, changes in diets in terms of lower red meat, saturated fat diets. These things have also led to decreased mortality over the years. And finally, this small sort of purple line is showing what the contribution of advances in treatment. And so, you know, there are real advances, but they're much, much smaller, a lot less bang for your buck than screening and modifying your risk factors. So we've discussed, or many of the speakers before me have discussed the risk factors for colon cancer, and I'll just quickly go through with you again. So age, and there's not much we can do about that, and 90% of cases occur in people 50 years or older, hence the recommendation for the average risk person getting screening colonoscopies at age 50. Gender, in general, men and women have about equal incidence of colon cancer, although there's a slight male predominance. We heard about increased risk in African Americans, and also an increased risks in patients with a personal history of inflammatory bowel disease, the Crohn's disease or ulcerative colitis, as well as polyps or colon cancer, or a family history of polyps, colon cancer, or different syndromes, as Dr. Smith discussed. And then finally, lifestyle. So smoking increases your risk, as does decreased activity level and certain dietary indiscretions. So looking at who gets colon cancer, and this was already discussed, you know, most of the cases we can't really identify one mutation. And so we call these cases sporadic, and that's the great majority of colon cancers are sporadic. We don't really understand what's causing them. About 10 to 30% of patients have a family history of colon cancer, and then there are the more rare hereditary syndromes that Dr. Smith discussed. Again, just to show you how colon cancer develops from the normal colon to the adenoma or polyp, and then to carcinoma. And during the sequence, there are multiple mutations that occur in a stepwise fashion an upregulation of various factors that kind of feed the polyp and lead it to become a cancer. And this is not a very fast process in the general population. It occurs over a period of 5 to 10 years, and that's why the interval between screening colonoscopies is 5 to 10 years. So how do we diagnose colon cancer? So we've talked a lot about colonoscopy, which looks at the entire colon. Blood tests are also used, more to help characterize your overall health. And then a CEA, which is a tumor marker you may have heard of, is often used to actually follow the presence of colon cancer after you've already been diagnosed. Imaging tests, so as we heard from Dr. Makari, also are very important in telling us where else in the body the cancer exists. And then, of course, surgery, which will give us an understanding of the extent of involvement of the tumor. So how do we stage colon cancer? Everyone wants to know about what stage they have when they're diagnosed. So here you can see that stage is dependent on the thickness with which the tumor penetrates the bowel wall. So this is the inside of the bowel, and the tumor starts growing, and it grows out through the bowel wall. And so the further it goes along into the bowel wall, as well as whether or not these lymph nodes here are involved, determines the stage. And looking at people who are diagnosed with cancer, the majority of cancers are diagnosed before they've spread outside the colon, which is the good news. So about 40% are stage 1 and 2. So these tumors have not spread to the lymph nodes. Another 40% have spread to the lymph nodes but have not spread distantly. And finally, there are about 20% of patients are diagnosed with disease that has spread outside of the colon to areas such as the lungs or liver. So why do we care about the stage? What is the significance? So stage is directly tied to your prognosis. And so here you can see, and these are again averages, 5-year survival rates for patients who are diagnosed with colorectal cancer. And here for all stages you see there's a 65% 5-year survival. For localized, so stage 1 and 2, so again speaking to early detection of the cancers, there's an 80 to 90% survival. As we get to stage 3 disease, survival decreases a bit, anywhere from 40 to 70%. And for patients with distant disease, there's about a 10% 5-year survival. So what are the goals of treatment for colon cancer? So treatment is really defined by both the stage and the type of cancer. So for patients with early disease, the goals are to remove the cancer cells, of course, to kill the cancer cells, and to keep the cells from returning. For advanced disease, the goals are to slow or to stop the growth of the cells, and to, of course, manage quality of life concerns. And it's important to note that each individual responds differently to treatment. So it's very important to communicate with your healthcare providers. So what are some of the treatment options? We talked about surgery, and there are different types of surgery as outlined by Dr. Bernstein. Radiation therapy, and as was discussed, this more plays a role for rectal cancer and is very rarely used in colon cancer. Chemotherapy, and so I'll talk about when we use chemotherapy in a little bit. Clinical trials, and I'll go into a little more detail about what is a clinical trial and how that may or may not help you. And then certainly complementary therapies such as acupuncture, nutrition support, dietary support. These are all very important in the treatment of colorectal cancer. So how do I make a decision when I meet someone about treatment? Because there's a lot of different types of chemotherapy to choose from. So important factors that go into this decision are the type and stage of your disease, the specific genetic makeup of your colon cancer. We can now test we now know a lot more about biology of colon cancer, so we can test the tumor for various mutations, which will help inform our treatment decisions. Your age and your overall health. So if you have other medical problems like diabetes or heart disease, these are going to play important roles in helping me to decide what type of treatment is best for you. Whether or not you've had cancer before or treatment in the past, because this will potentially limit some of the options. And then your willingness or ability to tolerate certain side effects, whether that be hair loss, fatigue, etc. And I'll talk a little bit more about that. And then ease and convenience of a treatment. Will you be willing to put up with an intravenous medication, or do we want to try to come up with an all-oral regimen? And of course, unfortunately, lastly, insurance coverage and costs for practical reasons. So what are the types of chemotherapy? You can break it down into three different general types. There's something called adjuvant chemotherapy, which is given after surgery to maximize a patient's chance for cure. So I'd like to call this risk-reducing chemotherapy. There's also something called neoadjuvant chemotherapy, and this kind of chemotherapy is given before surgery, and it's generally most often given in rectal cancer, where we're trying to downstage the tumor and often spare that sphincter that Dr. Bernstein was discussing. And then finally, palliative chemotherapy, which is given to patients whose tumors cannot be removed to delay or reverse their symptoms and hopefully to not only extend their length of life, but also to improve the quality of their lives. So now let's talk about stage-specific therapy. So this is a picture of a stage 1 colon cancer, where the cancer has grown through the first sort of layer of the colon wall and has started to invade the muscle layer. And treatment here is surgery alone. As I said before, with surgery alone, there is a 90% cure rate. So these people, generally, you do not come to see me, the medical oncologist. You're managed by your gastroenterologist and surgeon. Stage 2, the cancer has grown beyond this muscle layer in the wall of the colon, but has not spread to the lymph nodes. And in stage 2 colon cancer, surgery, of course, is indicated, and in some cases, chemotherapy may play a role, but that is only in certain cases. The majority of patients, again, 80% or more, are cured with surgery alone. For stage 2 rectal cancers, generally they are treated with preoperative chemotherapy and radiation combined, followed by surgery. And now stage 3 colon cancer. So this is when the tumor has spread to these adjacent lymph nodes. So the tumor is removed with the surrounding lymph nodes, and then chemotherapy is indicated, generally for a period of 6 months following surgery. We give chemotherapy to reduce the risk of the tumor coming back. And in stage 3 rectal cancer, again, chemotherapy and radiation prior to surgery. And finally, stage 4, when the disease has spread outside of the colon, chemotherapy is the main treatment modality in this setting, and surgery is really used for cases of bleeding or obstruction, as Dr. Bernstein had mentioned. And additional surgery can sometimes play a role to remove certain metastasis, and this is on a case-by-case basis. So let's take a look at the different chemotherapy drugs that are available. There are currently 7 FDA-approved chemotherapy drugs for colorectal cancer. And for the first, since the 1950s, we've had 5-FU, or 5-fluorouracil, and that was really the only drug from the 1950s to the 1990s. And in the mid-1990s, there were 2 additional drugs, oxaliplatin and irinotecan, which were introduced and led to a lot of advances in survival rates. Next, in the early 2000s, was capecitabine, or Xeloda. And this medicine is an oral drug, it's an oral drug oral 5-fluorouracil. So it made delivering the chemotherapy a lot easier in a pill. Of course, there are side effects to pills, so, but it did change the delivery mechanism. And finally, in the green, you see Avastin or bevacizumab, which you may have all heard about, which is a biologic agent. It's an antibody that inhibits blood vessel growth and starves the tumor, as well as these two agents, biologic agents, panitumumab or Vectibix and cetuximab or Erbitux, which are also antibodies that target something called the epidermal growth factor receptor. So these were great advances that we most recently have had in this field for chemotherapy drugs. So what have these drugs done? So what you can see here, without any treatment, and this again is talking about advanced disease, so metastatic or stage 4 disease, with no treatment, average survival is about 4 to 6 months. With 5-fluorouracil, the drug we've had since the 1950s, this extends survival to about 10 to 12 months. Then in the 1990s, when oxaliplatin and irinotecan were introduced, we're talking about survival rates 15 to 20 months. With the addition of the first biologic drug in combination with the others, we're out to 20 months. And currently, with all of these drugs combined in various different settings, average survival is now more than 2.5 years. So we have made progress little by little. And most of this progress has really come in the last 10 to 15 years. Just to talk briefly about what are targeted therapies or biologic agents. So these are medicines which work through specific pathways involved in cancer growth to attack cancer cells directly. And as I mentioned, the epidermal growth factor receptor inhibitors, Erbitux and Vectibix, and then the vascular endothelial growth factor inhibitors, the medicine that starves the tumor's blood supply, Avastin. And these targeted therapies are, in general, cause fewer side effects since they attack the cancer cells more specifically and directly. So this is just sort of a very simplistic slide talking about some of the side effects that can be seen with chemotherapy. On the left side, this is more side effects one would see with conventional chemotherapeutic agents. So diarrhea we often see, fatigue, mouth sores, lowered blood counts leading to anemia, something called hand-foot syndrome, which is a redness and sensitivity in the palms and soles, and then neuropathy or numbness and tingling. On the right side here, these are some of the side effects we see with the newer biologic agents, high blood pressure, skin rashes, bowel perforation, and allergic reaction. I think these are quite rare. So now switching gears to the role of clinical trials for the treatment of colorectal cancer. So what are clinical trials? Clinical trials are research studies which involve people, and the goal is to test new treatment and prevention methods to determine whether these are safe, effective, and better than what's the best known treatment. And so people are very hesitant about clinical trials and worry they're going to be guinea pigs. But I just want you to note that every colorectal treatment regimen that we now have, that whole timeline that I showed you, all of those drugs were developed as a result of clinical trials. Patients who had participated in studies that led to these drugs being FDA approved. The purpose of the clinical trial is to answer a specific medical question in a highly structured and controlled process. And clinical trials can evaluate methods of cancer prevention, screening, diagnosis, treatment, and quality of life. So when we talk about clinical trials, you might hear about different phases. So just to kind of give you definitions, a phase 1 clinical trial is a trial that determines the safety and the dose of a new treatment in a small group of patients. These studies are usually about 20 patients large. A phase 2 study looks into more detail about the safety of the new treatment and determines how well it works for a given form of cancer, such as colon cancer. And phase 3 are generally much bigger trials that take a new treatment that has shown promising results when used to treat a small number of patients, and then looks at this in a much bigger population and compares it to the standard to see if it improves outcomes as compared to the standard treatment. And so that's how we get our advances. In clinical trials, patient safety is very important, and so informed consent is key. So all participants should understand why they are being offered the clinical trial and the potential benefits and risks. And this is an ongoing process. It doesn't just start at the beginning of the trial, but occurs throughout the study as we learn more information about the medicine or the whatever we're testing. And participation is always voluntary in a study, and you can leave the study at any point, and I think that's an important point to remember. And then there are also other safeguards that exist throughout the study to make sure that safety is an ongoing issue. So just looking at some of the clinical trials we have here at NYU, this is not a whole list, but just a quick little summary. So we have a study for patients with stage 3 or lymph node positive disease, looking at the number of chemotherapy cycles or the duration of treatment. So is 3 months as effective as 6 months? Can we avoid the excess toxicity? We also have a study in the advanced setting looking at a combination of cetuximab, which was the EGFR, epidermal growth factor receptor inhibitor, and a new anti-vascular drug. And finally, there is a study looking at a specific subset of colon cancer patients with specific mutations and seeing if we can overcome this mutation with a new oral chemotherapeutic agent. So a lot of times when I see my patients and we've completed the chemotherapy, everyone asks, well, now what can I do in terms of minimizing my risk? I've taken the chemotherapy, and what else can I do in addition to chemotherapy? So we've repeated this a lot, but smoking cessation certainly is something that you have in your power, albeit it's often difficult, but we can help you through that. And then maintaining a healthy weight. So certainly it's been shown that patients with a high body mass index have an increased risk of disease recurrence and death. Engaging in regular exercise, so 3 hours a week of moderate physical activity after colon cancer diagnosis has shown anywhere from 39 to 59% decreased risk of colon cancer death. And a 50 to 63 decreased risk of total death from anything. So exercise is very important. And then, of course, dietary choices. So diets higher in fruits and vegetables and less red meat, as well as whole grains, have been shown to lower the risk of colon cancer recurrence and death. So just to kind of sum up, if the trends from 1995 to 2000 continue in terms of risk factors reduction and screening as well as treatment, then death rates from colon cancer can be reduced by another 36% by 2020. If we do an even better job of screening, continue to make more advances in treatment, that number can get down to 50%. Research. So this is important in terms of our future treatments, because with an increased understanding of the molecular changes, we can make better and better targeted agents. And finally, personalized medicine, which is important to try to avoid treatment in those patients who don't need anything further after surgery, and focus our more intensive treatment in those patients who have a more aggressive tumor biology. And so I just want to say thank you, and remember, colon cancer is preventable, treatable, and beatable.